Good afternoon, everyone. My name is Alison Kitson, and I'm delighted to be one of your lecturers in the University of Sydney's Distinguished Nursing Lecture Series. I am the Vice President and Executive Dean of the College of Nursing and Health Sciences, Foundation Director of the Caring Futures Institute, Associate Research Fellow of Green Templeton College, and also a co-founder of the International Learning Collaborative. Before I go into my presentation, however, I would like to acknowledge the traditional owners of the land upon which I'm doing this presentation, the Kaurna people of South Australia, and pay my respects to elders past, present and emerging. Now, you might think this is a bit of a dreary, horrible subject, why we need a caring life course theory. But I have a band of collaborators who have been working together over this last year or year and a half on trying to push our thinking, our theoretical understanding of what care is, why it's important, and how we can move it forward. As you can see, myself, Beck Golly, Julie Radcliffe, Beck Feo, Joe Archuli, Sally Robinson, Michael, Robin Clark, and Belinda Lang are either postdocs working in the Caring Futures Institute or leaders across our themes. So what I'm going to do today, and apologies, I decided that you would have the full frontal exposure to the PowerPoints, so I will be ducking in and out of this presentation depending on how much of the important information that I block on the screen, so hopefully that's not too distracting to you. So we're going to start off, well, what is the problem that we're trying to solve with the Caring Life Course theory approach? Give you a bit of background to that, the elements of the proposed theory, how we're going about refining and testing it, and then next steps. So it's probably a truism to say that from the moment we are brought into the world to the moment we exit the world, there is one thing that unites us all, unassailable. We are united by our need for care and the ability of other people to care for us. Now, you would think that is a pretty self-evident statement to make, but yet we know that there are a whole range of different experiences of care, and we only have to think about the two current big Royal Commissions that are taking place in Australia, Aged Care Royal Commission into Disability, to know that even though it is a life-giving attribute, care, being able to care for yourself, there is huge variation. We would have an assessment about this individual. We would think that there's a few bits missing to his care. Equally, we have wonderful examples of how people can live fulfilling, brilliant, excellent lives for half a century when they are totally dependent on other people's care. So care is not a function of how much you can contribute. Your need for care is not a function of how much you can contribute to society. Perhaps it's more a question of the lack of care is a symbol of our lack of ability to have some sort of social equity and social justice happening. So if care is so important, if it's what sustains us, nurtures us and gets us through life, then what is the problem that the Caring Life Course theory is trying to solve? Well, there are a number of things that the literature and multiple empirical studies have shown us that, first of all, care is not being provided consistently or in many cases to an acceptable level. Care tends to be episodic, clinical, and crisis-related rather than relationship-based, incremental and seamless. And those three elements, relationship, incremental and seamless, are important rhetorical statements, certainly in the quality and safety and in the patient person-centered narratives. And despite the rhetoric of integrated care, often many people's experiences is one of fragmentation, gaps, blockages and frustration. Also, what we found, again, from several decades of research into nursing interventions, is that often it's the basic or essential or fundamental care needs that are often the first casualties in a system, and that is often described as missed care or failures in care, or even some academics are now describing it as neglect. Such care is often perceived as common sense. So again, that's what we often hear, that people don't appreciate fundamental care delivery because they just think everybody can do it because it's such a universal necessity. And yet, you know, like nobody says, well, you don't need respiratory physicians to study breathing because everybody does it. That's the same level of debate that we need to move people out of. We need a really deep and thorough understanding of what care is and how we deliver it, hence the need for a theoretical framework. So given that that's the problem, the question we have to ask ourselves is, why are we still in this situation? And just again, I know those of you will be questioning the statements and will require an empirical base. Even though you can't read it, I can send you the slides. These are all the sort of pieces of empirical evidence upon which we have drawn our argument. So what are we going to do about it? Well, absolutely, the work that I'm going to share with you as it in representing the team is not, it just hasn't come out of the blue. We are standing on the shoulders of philosophical and other discipline giants, as well as giants in nursing theoretical discourse. And I think it's really important that we acknowledge that this work has come from a very deep and synthesized understanding of the way that people have been grappling with this. So if we take a quick sort of romp through the last 2,000 years of history, the things that I want to show you are that, interestingly, the very first goddess of care, called Cura, came from Roman mythology. And what's interesting is that story challenged the Christian story of Adam and Eve, so that it was Eve that was made first, or the equivalent. And it was Cura who argued with the gods used to introduce a way of absolutely aligning the spirit and the humanity of the individual. Now, I'll not tell you who lost that battle, you can go and read it. But what that sort of reflects throughout our human history, and particularly in philosophical development, is that this tension between spirit and humanity, the tension between intellect and consciousness and the reality of bodily experience, is something in addition to the whole quest for understanding in life, for meaning and for understanding good benefits, things that are harmful to us, has gone through all of the great literature. So Goethe from Germany, Kierkegaard, who would be someone that you would know from how he has influenced existential thinking and phenomenology, to Heidegger, who again talked about the importance of this notion of Sorge, or care and concern, and that whilst that was a very individual interpretation of how we have to think as individuals about what we care about and how that helps us understand life and living, it was our 21st century or 20th century social psychologists like Erik Erikson who shifted the gaze on one individual's self-reflection to actually thinking about that notion of interdependency. And this was then reinforced by, I can't read his, Merov, yes, the guy who, again, absolutely started to help us think about this interdependency around care. So these were broad philosophical movements in the middle of the 20th century that surely did influenced the way that nursing was developing its theoretical understanding. So again, we would all be familiar with Virginia Henderson's 14 activities of daily living. Equally, her definition that's been embraced by the International Council of Nurses a long time now, that the nurse was absolutely delivering care, helping the individual that couldn't do things for themselves. This was very much picked up by Dorothea Orum's general theory of nursing, where she talked about universal self-care needs and deficits. Equally, Carol Gilligan in the 80s took a feminist lens onto this and really reinforced the moral authority and the relationship-based aspect of being able to care for people, whilst Jean Watson absolutely took a more existential or presencing approach, that the encounter, the relationship-based care was really important. I think Florence Nightingale certainly was the pivot that sort of moved caring in the 19th century from being something that was akin to domestic service into something that was about empirically based observation. And obviously we have a huge wealth to draw from. So why are we absolutely arguing that we need to take a new look? I'm getting out of the sort of the gaze of the camera, because actually this is really important to understand the rationale for the caring life course theory. So again, just reiterating, despite requiring care from birth to death, a person's universal or fundamental care needs and the subsequent care provision, either by self or others, has yet to be presented within a life course perspective. So this is the first time, to our knowledge, that we are absolutely taking a systematic approach to the care through the life course. And by doing that, we're accurately describing the care people require across their lifespan, which enables us to identify who, what type, how and where this care should be provided. And that speaks to the importance of continuity and integration. And this novel perspective can help us to legitimize a person's care needs, therefore not making them feel less than human when they need care at a certain point in their time, and the support that they require from the wider care systems and contexts. So that's really making an argument that we shouldn't see care and the need for care as something that has negative connotations. It's absolutely a right, it's a necessity, and we would be arguing that in every advanced society we should be thinking of care as a right that is best articulated and delivered through the life course. So how the theory works? Well, we have developed 14 constructs, and they are essential to the theory, and we propose that it is possible, using these constructs, to generate caring life course trajectories and predict divergences in those trajectories. That means it can start to predict when a person will need help, how their care network needs to come together. And the novel contribution of the theory is the interplay between understanding a person's care needs and the provision within the context of their lifespan and personal histories, which is called their care biography. So just as everyone has a health record, we're arguing that everyone has a care biography. And if we were able to put the care biography together with the health record, just think of how we might be able to absolutely address the legion of gaps and problems and duplications that we have in our systems. So, and the theory has, at the minute, it has face validity, and we will be now undertaking a whole program of research to undergo empirical testing. So the methodology that we used to generate this theory was an inductive approach, drawing upon existing literature and the team's diverse experience. Certainly, myself and my team brought in over a decade's worth of work around the fundamentals of care framework, and the work, again, of our international collaborators within the International Learning Collaborative. The authorship team represented a wide range of disciplines: nursing, psychology, health economics, nutrition, dietetics, disability physiotherapy, to name but a few. And we reflected a range of research approaches, ranging from positivist to realist and critical social theory. Our theoretical insights were refined through a series of collaborative meetings to define the theory's constructs, and we did that until we couldn't think of anything more to do, or in other words, until theoretical saturation was reached. And certainly from the perspective of the fundamentals of care framework and its development, consumers were involved in that co-design right from the start. So what I want to do in this presentation is really describe the three steps that we've taken to construct the Caring Life course theory, starting with the building blocks, then moving on to how we understood the theory from the perspective of the person receiving and needing care, and then finishing off by looking at the theory from the perspective of the person or people providing the care. So let me just take you through this. Now, again, starting with the building blocks. It's actually interesting to go back and look at where the notion of a life course perspective to health and well-being emerged, because it's actually a relatively recent phenomenon. It's probably it's sort of in the early 1900s, and again you can see that there was a lot of stuff happening in sort of scientific discovery, certainly genetics, evolution, understanding of psychology, childhood development, and all of those things started to move down through the 50s into people actually beginning to realize that, again, and it's really promoted now in childhood epidemiology, or looking at the impact of the early years of life, the first 2,000 days, how that can predict what's going to happen to us as we age from a health perspective. So that's a very strong way of thinking about us understanding these big, wicked problems. The other building block that we put into the equation was the, as I've mentioned already, the fundamentals of care framework. Again, very much empirically based, and instead of saying that basic or universal care is common sense and straightforward and easy, we're arguing that the delivery of fundamental care requires three dimensions to be understood and activated. One is being able to develop the relationship with that other person or people, being able to integrate the physical, psychosocial, and relational aspects of care, of fundamental care, i.e. eating, breathing, going to the toilet, having a dignified experience, and having someone who you can talk to who understands and respects you. That's the sort of stuff we're talking about. And the context of care, where you do it, how you do it, and the frameworks, either legal or other types of frameworks that you need to work in. Within the central element of the fundamentals of care framework is this notion that care is based on relationship, very much consistent with all of the great theorists that I've spoken about before. The work that we have done has said that trust, positive relationships are based on the ability to form trusting relationships, and elements of a trusting relationship, particularly for nursing, is that ability to focus, anticipate, know, and evaluate each encounter. Big ask, complex, lots of skill required. So if you put these two building blocks together, the notion that we can start to articulate or record a person's fundamental care experiences through the life course, how could we construct that into some sort of anticipatory or way of beginning to start to predict what might happen and diagnose how we could make interventions. So the building blocks are the life course assumptions are what happens, as I've just said, early on in your life affects later experiences, both intrinsic, i.e. stuff that happens inside you because of your genetics, and extrinsic factors, i.e. Where you live and what postcode you're from, affect an individual's life course. We know that already. Transition points can affect abilities to manage, and of course life course care trajectories can be anticipated. Again, that those are well developed, well rehearsed constructs from life course theory. Fundamental care need assumptions. I've again already sort of mentioned these, but meeting another person's fundamental care needs is based on a trusting relationship, and that also requires the person to be able to actively integrate physical, psychosocial and relational needs dynamically, because they don't ever stay still, and that context, i.e. the external environment, affects how, when, where and by whom fundamental care needs are met. So moving on to the second step, so we've got the building blocks, so those are the two big sort of scaffolding that we're going to sort of hook this theory, and the theory relates to the experience of the person receiving or needing care, and then we'll move on to the perspective of the person or people providing the care. So what do we want to say about care from the perspective of the person receiving or needing it? Well, the question would be, how do you put these two perspectives, i.e. the life course and the need for care, together? Are we clear? Are we all agreed on what fundamental or universal care need is and how they should be met? Whose job is it to meet other people's fundamental care needs if they can't meet them themselves? And equally, how would we know that we're assessing, delivering and evaluating fundamental care effectively to meet another person's needs? And how do individuals themselves judge whether their fundamental care needs have been met? Now you can see that we're generating a whole bunch of researchable questions, and we haven't even talked about a clinical condition yet, and that's because we're arguing that we need to get these basics understood, conceptually, robustly developed before we absolutely move to the next thing. So in the theory, a care need is defined as a physical, psychosocial and relational need throughout the life course met by oneself and others. So it's a sort of like a modified Maslow, in that we're sort of focusing on the things that keep you alive rather than things that might effectively help you self-actualize, if you're familiar with Maslow's work. All of this is now being published in the Journal of Advanced Nursing, and if anyone wants to read this and look at it in more detail, definitely this is where you'll get the information. So, how we then started to construct the, just move my lectern so you can see the bébé. Okay, so first proposition is that you've got on the left-hand side up the vertical axis is care need, and across the horizontal axis you've got life course, birth to death. What we're arguing is that the proportion of care needs, so everybody will have care needs, and those needs are met theoretically through a mixture of what you can do for yourself, i.e. self-care, and care from others, i.e. what you need to receive from other people within this trusting relationship, and that happens across the lifespan. And again, you can see from as everybody would expect, at birth you are highly dependent, and as you go through your life course, there would be a sort of an expected trajectory that your self-care needs increase, therefore your care from other people decreases, and then the trajectory would increase, and often it can increase very it can either increase incrementally or quite dramatically, depending on a transition or a trajectory. So under what conditions do care needs vary? Well, as we said earlier, that's either things that you inherited, your health, wellness, well-being, mental, emotional, genetic, behavioral predisposition. Extrinsic is your family network, your socioeconomic conditions, and your the context in which you work. So that then means that if we think about the way that we're looking at care needs, so that's CN, so in a state of equilibrium, what you would always be looking for is where care need equals care provision. That's your ideal state. So that's like universal health equivalent, universal care equivalent, and care needs equals care provision when there is the right proportion of self-care and care from others. Now, of course, given now that you've got a formula, you know that with every formula you can start to play around with the variation. So that's what we did as a research team, as a theory development team, trying to look at the sort of hypotheticals around would we be able to plot when self-care was you'd had too much of it, or you had not enough care from other people, and how could we model that? So again, these are two hypothetical cases that we have developed. One is the blue line is saying that a person with very high dependency throughout life. So that's possibly, if you think of the example of Stephen Hawking, you know that he was totally self-caring until the age of 21, and then from 21 to 75, he was at a very high level of care from others and in fact, no self-care ability. Did that make his life not worth living? No, it just meant that he was more dependent on care from others. Equally, if you look at the orange graph, that shows someone's trajectory of being self-caring, and then a couple of incidents throughout their life course shows that they need more care from other people. And again, depending on whether that was delivered or not, that could have had an impact on their outcome, their caring experience. So we say, what is care provision? Well, it's the enactment of care abilities and activities, either by oneself or others, to address an individual's physical, psychosocial and relational needs at a given point in time. So again, we've talked about this. The situation is that care needs could be greater than care provision in three hypothetical situations. One is where you've got the self-care ability of the individual is insufficient for them to take control, which means, and that if that's not compensated for by someone who is looking after them, then you have care needs are greater than care provision. So let's take a young adolescent who has type 1 diabetes and who basically is still in denial. So they are not starting to manage their diabetes, and the care from others, their doctor, their family is saying, well, we're not going to do that for you because you should be doing it for yourself. That is an interesting scenario, and I'm sure many nurse practitioners or people who are working with those populations could resonate with that story. Equally, a situation where the self-care knowledge and self-care capability are acceptable, but care from others is low, may be an individual who is wanting to control their weight, but their diet and exercise is compromised by family circumstance, leading to poor food choices. And we have a number of, again, stories on the media that often talk about, you know, if you feed people for a month on cheap food with high carb, high fat, high sugar, it's amazing just how big an impact that has. If a family has insufficient funding, then how do we change that? The final one is where you've got low self-care and low care from others. And again, that could be illustrated with a preterm birth, a single mother who has just been told she no longer has a house to live in. Again, pretty common scenarios. Nursing and other carers involved with this realize that it's a complex, wicked problem to sort. So this illustrates the fact that, again, you can start to hypothesize or sort of postulate how care need and self-care and care from others could have points of variation, and depending on your assessment on that particular situation, that individual, that family, that care network, you can begin to work out what your intervention strategy might be. So that's care from the perspective of the person receiving care. Two big ideas: self-care, absolutely essential, central, and care from others. Now let's move on to the third step, which is the perspective of the person or people providing that care, and that's people like you and me. So how do we understand what our role is? Well, from the perspective of the person or people providing care, question would be, how do we systematically describe the experiences of people who choose or who requested or required to provide care for others? So the features that we're arguing in terms of our theoretical framework is that it has to be based on relationship rather than on a transactional basis. So task and time cannot be the primary way that you view the quality of care for other people. It has to be undertaken within a moral or ethical framework, and that very much speaks to Carol Gilligan's work and other philosophical theses. Care provision relationship is constantly negotiated and evaluated by all parties involved. So it isn't you write a care plan and that's it. It's dynamic, it's negotiated, and that is what creates the complexity and the art and the science of it all. Care for others are care actions or processes provided by others to address a person's physical, psychosocial and or relational care needs. Care for other people is undertaken by family, friends, formal, professional, health, medical, disability and a social care workforce. So there's a team, there's absolutely hundreds of people that will be involved in some of these things. And if you think of it through the life course, you can think of the agencies, the industries, the economic sort of implications of getting some of this right. So care for others is shaped by an individual's care transitions, care trajectories leading to bespoke and longitudinal care provision packages recorded as part of an individual's care biography. So care provision packages are worked out by considering the proportion of informal, formal and professional care needed from other people. So what does this look like on a graph? Well, basically what you've got is, and again this is our hypothesis, we don't, there is quite a bit of empirical work done, but not within a caring life course theory. But we would be saying that the bulk of care, and we know this, is undertaken by unpaid carers, parents, children, spouses, through a person's life course. Formal are these people paid carers like healthcare assistants or care workers, again, make up a significant part of the workforce. And then it's people like us, nurses, allied health, social workers, doctors, who will take up often the least volume of delivering care. So I think it's important for us to reflect on that and reflect, therefore, on the need for us to be able to understand who those other care deliverers are and how we, as potential experts or leaders in care delivery, can really bring together teams in an integrated way. Again, I would ask you to reflect on Stephen Hawking's experience, where from the age of 21 to 75, he was totally dependent on that army of 1, 2s and 3s, absolutely helping him through his very spectacular life. So, refining and testing the theory, and the good news is that we're almost finished, so thank you for holding on and doing a bit of brain gymnastics, because I know when most people think about theories, they think about, you know, having their eyes gouged out on things that they couldn't possibly think would be interesting. But my job is to try and get you to be excited about this stuff, because it is really, really, as Einstein said, there's nothing so, well, it wasn't Einstein, it was Kurt Lewin who said there was nothing so practical as a good theory. So how we're testing it? Well, again, the paper that we've published shows how we used the empirical work of 4 of our team members to start to model some of the way that we could sort of put some hooks on the Caring Life course theory. So Beck Golly and her colleagues, Beck is a nutrition and dietetics sort of researcher, and from her interest is childhood obesity. Wonderful randomized controlled trial, you know, looked at the intervention with the kid, tried to scale it up. What they then found was that if they didn't absolutely target the whole family, the whole network, they wouldn't either get, certainly wouldn't get sustainability, and they wouldn't get sort of prolonged weight, sort of healthy sort of weight management. So their work is already identifying the need for this care network and understanding the self-care and care from others element. The second example is from Robin Clark and colleagues, and Robin is a leading cardiac rehabilitation scientist. And what she has found is that the really important focus on enhancing self-care skills around diet, weight, and exercise, and how that has to be embedded into, again, the social care network. So it's not enough to target the person who's just had the cardiac problem and bring them into cardiac rehab. You have to think about the whole network, informal carers, formal carers, the way that people are going to think, talk, and support people who are now for the rest of their lives going to be thinking about weight, about salt intake, about diet, about social engagement. And these are big lifestyle changes, big care, self-care changes. The two are integrated, but they're not the same thing. Thirdly, we look at Joe Archuli's work, and Joe is a linguist by background, specializing in the language acquisition skills of young people with autism, and she's particularly interested in looking at enhancing literacy skills which lead to increased self-care ability and agency. Now, of course, it's a bit of a no-brainer to say that if you can't read or communicate, your whole ability to self-care is going to be compromised. So again, we see that the work that we're doing has significant impact on curricula, primary school, secondary school, you know, all of the ways that we amass, learn, understand what self-care is about. And finally, the example from Julie Ratcliffe and her team of health and social care economists looking at the the way that we can actually use some of the ideas within this Caring Life course theory to develop new measures or ways of measuring quality of life. So this is really, how do we measure the quality of life experiences that acknowledge the intergenerational and interdependencies of care and the care networks, so that it isn't just one sort of unidimensional notion of quality of care, that in our quality of care measures that are going to influence the way our government is going to put money into disability and aged care, how do we make it into a care systems approach, a care network approach that, as we know, is dreadfully lacking at the minute. So our next big challenges are, first of all, the impact for the Caring Life course theory. We argue that that will have a big impact on nursing, because it could provide a roadmap to inform nursing and other care industry sectors, providing opportunities to integrate and deliver care from the perspective of the person and their care history, trajectories, networks, and those of professional care teams. And we also argue that it can help shape the health, social, and economic policy involving individuals, families, and communities in more constructive ways of talking about the importance of care and how they can improve quality of life. So the next big challenges and answers on a postcard, a nice picture of New York. I wish, hopefully, we'll all be able to get in our plane sometime. So these are the things that we're currently working on. So if we are convinced, or if we think there's something in this theory, then what data do or should we collect around an individual's care biography? How do we store and use such data? How can we generate a unified care record that builds upon an individual's care biography over time, and that includes informal, formal, and professional care support and needs, and how those needs were managed? And finally, how do we generate a roadmap or multiple pathways that enable an individual's need for care to be recorded within a Caring Life course perspective? So you can see there's, as with most good bits of research or theories, we've ended up with more answers than questions. I know it's a lot to digest, particularly in this medium. Hopefully it's whetted your appetite to go and read the article. And again, those of you who would like the more detail on the work that we've done, again, these are a range of papers that you could choose to read. So thank you all very much. Hopefully you've enjoyed it. We'd love to hear from you. If you want to ask any questions, email me, Twitter me, or tweet me. And if you want to know a bit more about the International Learning Collaborative, then get hold of the ilccare.org, and many thanks.